Hello again, and welcome back to the Oncology Brothers podcast. I'm Rohit Gosain, and I'm here with my co-host and brother, Rahul Gosain. Today, we're diving into the world of gynecology oncology, starting off with endometrial cancer. As a medical oncologist, in our fellowship training, we often get limited exposure to gyn-onc, but out in community settings, we get to see a fair bit of this. When it comes to endometrial cancer, we have seen some significant advancements recently. To touch on this rapidly evolving space and to guide us through the current treatment paradigm today, we're joined by Dr. Shannon Westin, Professor of Gynecology, Oncology, and Reproductive Medicine at the MD Anderson Cancer Center. Shannon, thank you so much for joining us.
Thank you for having me. I'm so excited to be here.
Shannon, welcome. Shannon, can you start us off by just touching on different histologies that we see with endometrial cancer, be it serous carcinoma, clear cell, or undifferentiated, and then walk us through your basic workup. What does that really look like in your clinic for a newly diagnosed endometrial cancer?
Absolutely. So the most common histology type that we're going to see with endometrial cancer is endometrioid type, which essentially looks exactly like the cells that it came from. And those are typically going to be low grade, pretty bland, although we can see some higher grade endometrial tumors that will be a bit more aggressive in nature. The next most common is probably uterine serous cancer, which certainly is a more aggressive subtype. And then more rare subtypes are going to be things like clear cell, carcinosarcoma, and undifferentiated. And a really great rule of thumb is if it's not endometrioid type, it's probably fairly aggressive. I will say that we are slowly starting to move away from that complete definition of histology driven care and instead moving into more molecularly driven care. So we had the Cancer Genome Atlas, which looked at the molecular aberrations that are found in endometrial cancer and started binning them a little bit more related to that. In general, we still see separation based on the histologies, but for example, when we see a p53 mutation, even in an endometrioid histology type, that's going to be more of a bad acting cancer than some of the others. So I would just say that as an aside. But I think, for the purposes of the listeners, we're still sticking to kind of those basic histology types. When someone walks in the door with a newly diagnosed endometrial cancer, generally they've had an endometrial biopsy or a dilation and curettage, which is a surgical assessment of some kind to look at that endometrial tissue and understand what's going on. Generally, that's been in response to, vaginal bleeding or some type of abnormal symptom. Depending on the grade and histology, if it's an early grade endometrioid type tumor and the patient doesn't really have any symptoms other than bleeding, we often don't really get any other workup. We move almost directly to surgery. I mean, we do a medical workup. I know I've got lots of medical people on this podcast. We make sure they're medically fit for surgery. But, we don't do a big, imaging workup. The main thing I'll get sometimes is like a transvaginal ultrasound, let's say, to make sure the uterus is of a size that I can proceed with my surgery in a minimally invasive fashion. Anything kind of on the high grade side. So this is our grade 3 endometrioids, our uterine serous, clear cell carcinosarcomas, and undifferentiated. I'm going to image that patient prior to taking them to surgery because they have a higher chance of having advanced stage disease at diagnosis. And I want to know what I'm getting into. And I want to make sure surgery is the right choice. In general, if we can proceed with surgery, that is ideal in endometrial cancer. However, we're seeing a growing number of patients presenting with great, stage 4 disease that we can't remove all the disease at the time of surgery. And for those patients, there is a higher consideration around neoadjuvant techniques.
Well, thanks so much for touching on that. And you mentioned briefly about molecular classification. Sure, we're not completely there, but what does that molecular classification looks like for endometrial cancer, and truly how it impacts your decision-making process for a treatment standpoint?
Yeah, I mean, first I can talk about the diagnosis. The good news is this is now NCCN listed recommendations or a European listed recommendation. So we often can get these tests as standard of care. But the first analysis we need to do is determine if the patient has a POLE mutation. That's our first kind of separation. Then we look at mismatch repair, looking to see if the tumor is mismatch repair deficient or proficient, using typically immunohistochemical markers for MLH1, MSH2, MSH6, and PMS2. And after that, then we've been based on P53, either the presence of a mutation or evidence of wild type. And that can be done by IHC if we're needing to not do next-gen sequencing because of cost and other issues, or it can be confirmed utilizing next-gen sequencing. So that's the way that we separate them. It's still a little bit of work in progress how we're using that to define the patient in front of us and to define the treatment that's ideal. If you look at the new FIGO staging, they do actually incorporate molecular testing. It's pretty controversial because of that concern that not everywhere all over the world can get the next gen sequencing that's necessary for that POLE assessment and P53 assessment. But with that being said, there's a growing cadre of data to say that perhaps patients with tumors that have a POLE mutation, a true POLE mutation, may not need as much or may not need any therapy, that they may do well no matter what you do. And conversely, that patients that have tumors that harbor a P53 mutation may need to have a more aggressive therapy and may benefit from, additional treatments outside of, say, surgery in the early stage disease, or outside of, say, chemotherapy in late stage disease. And so I think it's still a little bit of a work in progress, but for the purposes of the community oncologist, if you're able to get next-gen sequencing, that's outstanding.
Okay.
I wouldn't at this point not treat a patient with a POLE mutation just because I don't think we quite have enough data. But I might consider, that additional adjuvant therapy in the presence of a P53 mutation. We can certainly talk about that a little bit more as we talk about some of the treatment strategies.
Absolutely. I think a few things to dissect here. In the community, we're so used to looking for these NGS mutations, be it for lung cancer and not for colon cancer. So at least in my practice, this often ends up being moving forward with NGS rather than looking for pinpoint mutations. And we'll dive into this a little later as well, because now we have more and more bucket approvals as well, be it for HER2 or NTRK. So keeping that information granted for metastatic disease also ends up being very important. So Shannon, coming back to the early stage, be it because of the histology or molecular classification, we often divide these patients in low, intermediate risk, and then high risk. You also touched on minimally invasive surgery. That's great for our patients because they're quickly recovering for that potential adjuvant treatment. So in your practice, based on the molecular classification or histology, how are you deciding who gets adjuvant treatment and what kind of adjuvant treatment?
Yeah, right now in general, we're utilizing just the typical pathologic features. So, depth of invasion, grade, and the presence of lymphovascular space invasion. But what we're learning really, especially with early stage, like stage 1A or early grade 1B, that probably less is more. And so the majority of those patients likely can and will have just as good outcomes if we observe them and watch them closely rather than utilizing adjuvant therapy. However, depending on kind of the overarching look at risk factors, and this is kind of the combination. So grade 2, let's say, of itself is probably not enough, but grade 2 in the setting of deeper invasion or in the setting of lymphovascular space invasion, maybe somebody that didn't have lymph nodes assessed, then we may be more likely to add something like adjuvant radiotherapy. And specifically in these early stage, early grade, we'd be looking at vaginal cuff brachytherapy. It's when we push into exactly what you said, that high intermediate risk, the higher risk, which is the deep invasion, the grade 3 is stage 2 for sure. That's when we start saying, okay, at the very least, we're going to use pelvic radiotherapy or cuff brachytherapy with chemo. And there was actually a pretty nice study that looked at that. It didn't find any benefit as far as survival for, what we affectionately call cuff and chemo versus full pelvic radiotherapy. But surprisingly, at least to us, was that the full pelvic radiotherapy actually had less side effects than the cuff and chemo. I think we were all expecting the opposite. I will say that this is a discussion I have with the patients in clinic.
Thanks for covering that, Shannon. Just from medical oncology standpoint, what does your neoadjuvant or even adjuvant treatment look like? Do you rely heavily on platinum in those circumstances where you have to utilize chemotherapy at hand? And one last tidbit to add there, any role of immunotherapy here at all?
Yeah, I mean, this is where all the excitement has been, right? So to be specific, we're looking at the advanced stage group, right? So stage 3, stage 4, they're often lumped together, and also often lumped together with patients that have a recurrence that maybe didn't get any therapy up front as far as chemotherapy, or only had a small amount of adjuvant chemotherapy. They're all kind of put together in this kind of large bucket of treatment as far as those patients are concerned. So, the bottom line is we use platinum-based chemotherapy. We typically will use carboplatin and paclitaxel. And that, in general, the best data that we have is using that in the adjuvant setting. So again, after surgery, after we've gotten our full staging done and resected all evidence of disease. However, because of our experience with ovarian cancer, and again, as I mentioned, because we're seeing higher stage cancers and patients coming in with extensive liver metastases or lung mets or mediastinal mets that I just can't resect as a surgeon, we are turning a little bit more towards that neoadjuvant strategy. And again, that would be that platinum-based chemotherapy with paclitaxel and carboplatin. So, that's one of the major options for therapy. I will say that chemoradiation therapy is still considered one of the options for standard of care for this same patient population, but more leaning towards that stage 3 population with nodal involvement. Been a couple of really nice trials looking at, chemoradiation versus chemo alone and chemoradiation versus radiation alone. And the bottom line is chemo's important. You need to have some chemotherapy. And potentially there's a population for whom some concurrent radiotherapy is probably a good idea. But again, for your listeners, when you look at the NCCN guidelines, it basically says you can do whatever you want. And so it becomes kind of a conversation again with the patient around trying to figure out the best strategy. So if we do chemoradiation, we do give it with cisplatin and then follow it up with that, again, paclitaxel and carboplatin. So pretty similar across those three. Now, with all that being said, if you've decided to give your patient chemotherapy, the question now is, should you add immunotherapy with checkpoint inhibition? And the bottom line answer is yes. So, and I'm going to get a little bit more detail oriented here, but that's the board's answer. That's the patient answer is we have to give checkpoint. I will say that just like with most targeted therapies and with these strategies that we have a biomarker, that if you have the presence of a biomarker, the patient is going to get more benefit, right? So specifically for endometrial cancer, the biomarker for immunotherapy is going to be mismatch repair deficiency or microsatellite instability. But we've got approvals across all comers, okay? So the best bang for our buck when we give immunotherapy with chemotherapy is going to be for those patients with mismatch repair deficiency. And we have FDA approvals across 3 drugs, dostarlimab, pembrolizumab, and durvalumab in that space. However, we still see progression-free survival benefit and even overall survival benefit for one of them in the kind of all-comers population. And so in that mismatch repair proficient group or microsatellite stable group, you can add dostarlimab or pembrolizumab according to current FDA approvals. If you have anyone that listens from Europe, we also have the opportunity to use durvalumab with olaparib in this patient population. So the bottom line is right now for mismatch repair proficiency, the best thing we have is to add IO. Do I think that's going to be the end all? No, I think there's going to be better stuff here. I think, and as someone who was a PI for one of these trials, obviously I'm very engaged in this piece, but we did well in the mismatch repair proficient, but we didn't do as well as we did in the mismatch repair deficient. So there's still opportunity for improvement. And in fact, this classification around mismatch repair proficient is probably too broad. We probably need to parse that out even more based on other biomarkers. So, to be determined where that's gonna lead. But I think, again, for the purposes of today, the patient in front of you, I absolutely talk to all my patients with advanced and recurrent endometrial cancer about the combination of chemotherapy with checkpoint inhibition, considering all the contraindications and such. This is the current standard of care.
Absolutely. Shannon, thank you so much for going over that. Again, the combination of chemo with immunotherapy is our current standard of care in unresectable endometrial cancer. But even dialing the clock back a little, is there a particular patient that you would consider adjuvant immunotherapy where you're worried about saying high risk features? Is it all stage 3? Is it all stage 3C or high risk? Who is the right patient in adjuvant settings for us to add immunotherapy? Is it everybody?
So right now it would be, based on what we know from the trials, is 3C, stage 4 definitely. And even early measurable stage 3 likely. If you couldn't resect that for whatever reason, those are reasons why we would add IO. There's additional data being generated for some of the earlier stage, and in fact should be getting presented over the next few weeks. So to be determined if we're looking at the addition of checkpoint even in the early adjuvant therapy with, say, cuff radiation or early radiation for early stage disease. So I think this is being explored quite a bit. So I definitely think from an adjuvant setting, it's really, really intriguing and should be considered. I also would be remiss if I didn't mention there are current ongoing trials in the mismatch repair deficient group that are looking to get rid of chemotherapy entirely, right? So can we give just immunotherapy like we've seen in some of the other solid tumors? Can we just give immunotherapy in this population? So those trials are ongoing and hopefully will report out over the next few years so we can answer that question.
Absolutely. Shannon, while we're at the topic of immunotherapy, if the disease was to progress, especially in the patients that are MSI-high or deficient MMR, would you re-challenge them with immunotherapy, be it pembrolizumab, or what's your usually next go-to if the disease has been exposed to immunotherapy upfront?
Yeah, I'm intrigued by this question. I'm not going to be able to give you a perfect answer. I can tell you I'm discussing it with my patients right now because we don't have the data. The combination of pembrolizumab and lenvatinib was so active in second line. It was in completely no prior immunotherapy population. We have some early retrospective data looking at this concept of immune checkpoint after checkpoint, especially with the combination with lenvatinib. And there is intriguing, especially in the mismatch repair deficient group. But I don't think we have enough data for me to confidently say, oh, yes, that's absolutely what I would do. I do talk to my patients about it and kind of work through those things. I am more intrigued about the opportunity to test for other molecular aberrations here and see if there's something that might make a little bit more sense rather than just adding lenvatinib to immune checkpoint.
And in terms of the NGS testing, we do that initially at the diagnosis time. Do you repeat that at all at a later stage to see if there are any new mutations that might have taken about?
We've started doing that. There's not a lot of great data here. The data that's been reported has all been small studies, and there hasn't been much change, at least from the genomic standpoint, in between, say, testing that was done at diagnosis and the time of recurrence. But if it's been, 3-4 years, yeah, I think it makes sense, especially as long as the patient's not going to get charged, depending on kind of the coverage and everything. I like getting something that's a little bit closer to kind of where we're at. And certainly things like proteins and things can definitely be retested, and certainly is a lot less expensive and easier to do.
And if the patient is rather platinum resistant, that is less than 6 months of therapy, the disease recurred, and now you don't have any molecular markers available to guide your treatment, or rather they're negative, what is your go-to chemo? Because you have various doublets and single agent approved here. How do you rely? Of course, we have to maneuver through comorbidities, side effect profile, but how do you maneuver through that?
Yeah, I think there's probably 3 combinations that are the most active, 2 of which are typically used as the comparison. for, say, novel treatments and things in trials. So that would be weekly paclitaxel and doxorubicin. They're both tough, right? They both have their own unique and specific toxicities. So we just talk through that with the patients and do our best to kind of guide them through and dose appropriately based on their existing comorbidities and their existing toxicities. The other combination that I love is gemcitabine and cisplatin. There was a small trial looked at this. We're actually looking at these data in our institution because we use it quite a bit. And I think the responses are really high, and it helps, that combination of the gem and cis helps overcome platinum resistance in both uterine and ovarian cancer. I know we're focused on uterine right now, but I think that combination is actually, when you give it biweekly, it's fairly easy to give. The patients tolerate it really well, and you can, dose adjust based on existing toxicities. And we've had a lot of really great activity with that combination. So I've been using that quite a bit lately.
Thanks. And Shannon, I feel like this podcast will be incomplete without touching on your DuoE study for PARP inhibitors with immunotherapy, as you mentioned earlier. Where do you see role of PARP inhibitors in endometrial cancer without clinical trials on board, at least something that we could utilize in community?
Yeah, I mean, as I kind of referenced before, we were really excited to get the approval in Europe for the combination of the durvalumab and olaparib in the mismatch repair proficient group. I think that's likely where the biggest benefit is. When we looked at, in post hoc exploratory analyses, obviously, like no stats, but when we looked at the curves of, mismatch repair deficient and mismatch repair proficient and the benefit of that additional olaparib, the curves looked like they were almost exactly the same in the mismatch repair deficient group. Olaparib really just didn't add much more. But in the group that was mismatch repair proficient, we really did seek some additive benefit, which is exciting. We're doing some additional analyses because I wonder if there may be molecular subtypes that really derive the most benefit. Early analyses has looked at things like BRCA mutation, right? Just like, ovarian and other solid tumors, looked at the presence of homologous recombination mutations. And that does seem to be where the most benefit is, but it's not all of it because those mutations are very rare in uterine cancer, and we still see benefit across that mismatch repair proficient group.
We will eagerly wait on this FDA approval, but just where we started before we close, NGS testing, we have bucket approvals for TDXD for HER2 positive disease. And actually, endometrial cancer had close to 60% response rate on this single agent.
Bonkers.
And then, of course, we also have NTRK as a bucket approval, but that's a very small population. Just before we close, Shannon, can you touch on the bucket approvals here?
Yeah, I'll start with the kind of sad news and then I'll go to the happy news. So NTRK, I personally haven't had one patient with endometrial cancer test positive for that fusion. And we are very fortunate to have the ability to test for that in the majority of our patients. And we really have had a big goose egg. So fingers crossed that one of the listeners has found someone. I would 100% use these drugs in my practice if I had a patient that tested positive. So with that being said, HER2 is a lot more positive. And in fact, when you look at traditional data, it would say that HER2 positivity was found, or activate amplification and such was found in about 20 to 30% of endometrial cancers. I think it's actually going to be much higher than that now that we're using that pure IHC 2+3+ designation. I feel like we're seeing a lot more of these patients, and I am using this drug. I think that trastuzumab deruxtecan is a great drug, and we've already had people that had like 8 or 9 prior therapies that finally, once we got that approval, we used. I have a lady that has a complete response. I mean, it's a legit drug. And you guys that do solid tumors, you've known this because it's breast and everything else. For us with Gyne, it's like, oh my God, it's so exciting. So yeah, I'm 100% a believer in that drug, and I'm trying to. We have tested all our patients. The one thing I will note, and you guys probably know this in the solid tumor world, is for a while some of the commercial tests for NGS were not doing IHC for HER2. They were doing only amplification. So you were getting reports that said people were HER2 negative. Definitely go back and check those reports, because if you go and check that protein, you may have some people that are positive that can receive this drug.
Absolutely.
I feel like TDXD is new immunotherapy when immunotherapy came back in the day.
Yeah.
Shannon, thank you
Totally.
so much for taking the time to reiterate the current standard of care for endometrial cancer. For our listeners, let us go over a quick recap. In today's discussion with Dr. Shannon Westin from MD Anderson, we had a chance to focus on the current standard of care for endometrial cancer, multidisciplinary approach, and working with your surgical and radiation colleagues is a critical part. We have also touched on how the treatment of endometrial cancer has evolved significantly, particularly with the use of molecular classification and introduction of immunotherapy.
In this discussion, we also had a chance to focus on the importance of NGS testing to ensure we can address any actionable mutations, be it MSI-high tumor or HER2-positive cancer. Thanks for joining us. Make sure to check out our other discussions focusing on ovarian cancer as well. We are the Oncology Brothers.